Good evening, everyone. I am Arpita from the IGCP group, and it's my absolute pleasure to welcome you all to today's insightful webinar. We are truly honored to have with us one of the most esteemed names in the field of ophthalmology, Dr. Kuresh V. Muscati, sir. It's an honor for me to welcome sir and introduce to everyone. Sir is done MBBS, MS, DOMS, FCPS, FICS, consultant ophthalmologist at Muscati Eye Clinic, Mumbai. Sir hardly needs any introduction. With a stellar career spanning decades, he has been a guiding light in advancing eye care in India and globally. Today, he will be speaking on the topic ABCDE of dry eye, a structured approach to ocular surface disease with case curves. Now, without doing any further ado, I would now request Sir to please start with this topic for today. Over to you, sir.
Thank you, Arpita. So I always say when I teach that diagnosing the problem of dry eye, you don't need sophisticated instruments. You need your ears more than your eyes. Just listen to the patient, and I'll show you with case studies also how simple diagnostic tools can help us to diagnose and decide what kind of treatment to do. Let us first start with basic anatomy. We should know our tears are the film which sits on top of the cornea. The cornea is the glass in front of the watch that is called the cornea. And there are three layers of tear film. Previously, it was thought that there were three separate layers like first floor, second floor, third floor. But now we know that there is a mix of the three. So the innermost layer which lines the corneal epithelium is secreted by the goblet cells, the mucin cells, and it is basically mucin. So mucin is the building block. It's the foundation on which a very large volume, 70-80% of the next block, the second floor, that is the aqueous component or tears, which is water. Mainly water. It is secreted by the lacrimal glands. The lacrimal glands are below the eyebrows, and there are pipelines which bring the water into the tears. So the second component, which is shown in blue, that is the middle layer or aqueous layer secreted by the lacrimal glands. And the superficial layer, the topmost layer, which is the third floor, which covers the tears and prevents the evaporation, is the lipid layer or the oil layer. It is secreted by meibomian glands or lipid or oil glands, which are in the lids. Upper and lower lids, we have about 20-25 meibomian glands. They secrete the oil. So again, to recapitulate, we have three layers. The innermost mucin layer, a large volume, which is 80-90% of our tears, which is the aqueous layer, and the outermost layer, which is the lipid layer, which prevents evaporation. Now, there are a lot of medical conditions which we should be aware. If we are a practicing family physician and a patient complains of dry eye symptoms, I'll tell you what the symptoms are. HIV/AIDS can produce dry eye. Many of the conditions I'm talking about, even the treatments that we give, the medicines we give for the conditions also cause dry eye. So acne rosacea can be accompanied with dry eye. And sometimes doctors give the tretinoin, a skin cream, which also can worsen dry eye. Chronic active hepatitis, Crohn's disease, graft versus host disease, infectious mononucleosis, Parkinson's, these are not so common. But hypertension, diabetes, hyperacidity, these are such common diseases. I practice in a city called Mumbai, and it seems to be that every second or third patient has got these stress-induced diseases or what we call lifestyle disorders, such as anxiety, depression. The medicines we use to treat hypertension, diabetes, hyperacidity, anxiety, and depression also worsen dry eye. Rheumatoid arthritis, Sjogren's, Stevens-Johnson, these are some of the uncommon. But thyroid is again quite common. In menopause, we must know that hormonal changes take place at that time. Sometimes we induce dryness by doing LASIK procedures. But let's talk about, so those are some of the medical conditions. Let's talk about, as I said, the ABCDE of dry eye, or 5 common non-pathological, as it were, conditions which cause dry eye and which you diagnose with your ears. So A stands for aging, B for blinking, C for contact lenses, D for drugs, and E for the environment. Let us just tackle each one of these. So A for aging, we must know that tears are 60% less at age 65 compared to age 18. So as we grow older, the body secretes less tears. So imagine an elderly 65, 70-year-old patient who's got borderline dryness because the tears produced are less. They can easily develop dry eye because the cataract surgery is done. Any surgical procedure causes a little disturbance to the neurons, and that can produce the neural loop is disturbed and you can get dry eye. A typical elderly patient comes to Mumbai from a small village where there is no pollution. He comes to polluted in Mumbai. There's a change in environment. Pollution causes dry eye. Then I diagnosed that he's got mild hypertension in the village. 130/90 was considered normal. But in Mumbai, we have famous MD cardiologists who say, no, no, it must be 120/80. Put the patient on beta blockers. The beta blockers will cause dry eye. I'm very careful to rule out diabetes in a cataract. And I find his blood sugar is 150, which is fine. He was a healthy patient in his village. But in Mumbai, 150 by my diabetic colleagues is considered too high. So they put him on sulfonylureas or other anti-diabetic medicine. Those medicines cause dry eye. So why a cataract patient is so prone to dry eye? Just because of these factors. So aging. B is for blinking. We know that inadequate blinking, God designed our eyes to have blinks. Every time we blink about 20-25 times per minute. That is what God designed. But sometimes we are so busy staring at the computer screen that we blink less. We stare at the screen. When we blink less, our tears evaporate from the open eyes. The lipid layer breaks and the tears evaporate. So more evaporation, so more dryness. So also when we blink, when we're staring at a screen or a gadget or a mobile, we get what is called as half blinks. God did not know about half blinks 40 years ago. But now we don't blink completely. So when we don't blink, the blink is only half. Again, tears evaporate. So inadequate blinking and less blinking. Both of these prevent the tears from washing our eye well. Or windshield wiper. If you imagine a windshield wiper on a car, it spreads the water from the rainy season from one side of the screen to the other. Similarly, when we blink, our tears get washed, wash the whole cornea and the ocular surface. They go from one side to the other. If that doesn't happen, the tears evaporate. You get relative dryness. It's called computer vision syndrome or CVS. Also, there is sometimes excessive blinking in children. They get a habit. They keep on blinking their eyes very fast. Again, the tears don't get time to spread evenly between blinks. So excessive blinking occasionally in children and inadequate blinking in adults on computers can cause dry eye. So B for blinking. C is for contact lenses. For those of you who practice in metros where a lot of people, especially ladies, want to wear contact lenses, even in elders, after the age of 40, they wear presbyopic contact lenses or bifocal contact lenses. Any contact lens gives an increased area of the surface for tears to evaporate from. So they worsen a pre-existing mild dry eye because they disrupt the tear film. So normally the tear film and the cornea are like the dog and cat in the picture in the cartoon, but the contact lens disrupts that unity. So C is for contact lenses. D is for drugs. I told you about some of the drugs that patients take: antihypertensives, antidepressants, even antihistaminics that people take for cold, decongestants which they use for the nose, diuretics for kidney patients, steroids. All these cause dry eye. And even those who are putting glaucoma drops lifetime, the preservatives in the glaucoma drops also cause dryness. Oral contraceptives can cause dryness. Hormones can cause dryness. Too much of coffee or alcohol can cause dryness. So D is for drugs. We need to be aware. Not that we want to stop antidepressants. The psychiatrists also have to make a living. But we have to be cautious. We know when to add some artificial tears. So D for drugs. And E is for environment, such as high altitude. Whenever you travel abroad, in the plane, or whenever you travel in a plane, the air hostess often makes the announcement that the outside temperature is minus 35 degrees, but for your comfort, the cabin has been kept at a pleasant 23 degrees. Now, that air conditioning in the cabin, which is there, all air conditioners, whether it's in the aeroplane, at high altitude, or if you're on climbing Mount Everest, the air is very rarefied, so it's devoid of water. If you're in a city like Mumbai, where I live on the 11th floor, I have an air conditioner which has a pipe attached to it which drops the water from my room onto the neighbor's balcony on the 10th floor. So the job of the air conditioner is to suck out water from the room. The room doesn't like to be without water, so it sucks out water from your eyes, causing dryness. So it's not only a sunny, dry, or a windy climate which can cause dryness, but even air conditioners and heaters, which are designed to suck out water, can cause a dry room, and therefore your eyes can become dry. And of course, the more the pollution, dust, if you're working in a chemical factory, toxic fumes, all this can cause problems. So, E is for environment. To summarize, you must keep a healthy clinical suspicion of dry eye. Ask leading questions about the work environment, whether the patient is wearing contact lenses, does the patient have any medical conditions, is the patient putting any drops or is taking any tablets like antihypertensives or cold medicine. Observe the patient as a whole when they enter the room. What is the gait like? If it's a rheumatoid arthritis, he will struggle to walk. If his fingers and toes are swollen, it could be rheumatoid arthritis. Is there a malar flush? Malar means cheeks. So is there a flush on the cheek? It could be acne rosacea. So more than 90% dry eye patients can be diagnosed with your eyes and ears alone by just remembering what I told you about ABCDE, where A is aging, B is disorders of blinking, C is contact lenses, D is various drugs, and E is environment. So it's not diseases alone, but our lifestyles which can cause dry eye. What are the symptoms of dry eye? So again, using just your ears, if a patient complains of tearing, why does a patient of dry eye complain of tearing? It's quite a funny thing. But 15% of patients of dry eye will complain of tearing. Why? Because our tears, as I told you, are that healthy mix of three components: mucin, aqueous, and lipid. If that is deficient, then the body responds by secreting from the accessory lacrimal glands excess amount of water. But that water doesn't contain all the components of tears. So it just tapkaus, it just falls off onto the cheeks, giving you watering, but actually the eye is dry. So burning sensation, sandy foreign body sensation, itching, photophobia, can't open the eyes in sunlight, redness of the eye for no apparent reason, fluctuating vision. Patient tells you, sometimes doctor I see well, sometimes I don't. Why is it so? Because our cornea, that you see the shiny cornea in the lowest picture, the shiny cornea needs a thin film of the tears on top to give it a perfect refracting surface. If the thin film of tears is lost, then the cornea becomes a little fuzzy and the quality of vision is not so good. So if he blinks his eyes or if he closes his eyes for 2 minutes, then again a thin film of tears comes onto the cornea and he sees better. So that is the concept of fluctuating vision. And sometimes, just like patients like to dig their nose, quite often you have this nasty habit which is very irritating. Somebody sitting in front of you and digging his nose. Similarly, when the aqueous component is lacking, the mucin collects on the side. As you can see in the lowest picture, you see this mucin over here, this muck over here collecting on the side. So they pull it out and it's quite stringy. So if somebody is pulling strings of mucus out from the eye, you can be sure that it's an aqueous deficient dry eye or the watery component is lacking. What are the signs that we as eye surgeons look for? Many times the dryness is accompanied by lid abnormalities, what we call blepharitis. There are two types of blepharitis. One is called squamous blepharitis, where you get dandruff-like scales on the eyelashes, and the other is called meibomian gland disease or MGD, where the meibomian glands are blocked. So the oil doesn't come out of the glands. And therefore, you can get frequent styes or you can get the telangiectasia, blood vessels near the glands becoming enlarged. Then because of the chronic irritation on the surface, you need the tears to give you a smooth surface. When it is not there, you can get chronic irritation, mild redness of the eye, what may appear to be a non-specific conjunctivitis. There's no virus, there's no bacteria. As dryness worsens, you can get what we call superficial punctate keratitis or SPK, small spots on the cornea. If we look at the tear film meniscus, all of us, we don't need a slit lamp, we don't need any sophisticated instruments, you don't need fluorescein stain. In the picture above, I've stained with green fluorescein, and you can see just above the lower lid a thin line of green. This is the lower tear meniscus. So we can see it even without fluorescein stain and get an idea of what is normal. And then if the tear film meniscus is lowered, that means the aqueous component is less. Then I urge you to pull the lower lid down. When you pull the lower lid down, the tears inside the lower lid should be clear, water. Sometimes you see kachara, mucus and debris in the tear film because the aqueous component is less, so it has not washed it away. So if that is so, then again you suspect dry eye. In late cases, you can get epithelial filaments, erosions on the cornea, and you can get a sagging conjunctiva. The above the lower lid, just like you get baggy eyelids, you can get baggy conjunctiva because of the chronic dry eye. That's called a condition called conjunctivochalasis. Let us now make it a little more interesting for you. We have studied the ABCDE of dry eye. We've discussed how the symptoms, watering can occur in about 15% of cases, and you can get non-specific redness and photophobia and fluctuating vision in the symptoms. And in the signs, you can get mild redness of the eye. You can get eyelid abnormalities, squamous blepharitis or meibomian gland disease, and you can get conjunctivochalasis. Let's talk about some case studies that I have come across. Let's talk about this patient one. This is a 50-year-old female, very angry lady with redness, foreign body sensation, burning, and blurry vision in both eyes. 5 years she's had these symptoms, worse in the last 2 years. When I went a little deeper into the history, she told me she also has dryness of the mouth, difficulty in spitting saliva, and the nose is always dry as well. Occasionally, she even had a nosebleed because of dryness in the nose. So current therapy, her doctors had put her because it was chronic. What happens? We start with teardrops, which is the mainstay, artificial teardrops. You get two types, preserved drops and unpreserved drops. The preserved drops contain preservatives. The preservatives themselves can cause irritation in an eye. So if you have to put the drops frequently or for more length of time, most eye surgeons go for what is called unpreserved artificial tears, means without any preservatives, so that the preservatives don't cause irritation. So the doctor had done what he thought was correct, put the patient on unpreserved artificial tears as many as 6 times a day. But the patient had only mild relief. You see how she's still complaining over there. So I said, let me search for clues. So in both the eyes, the visual acuity was not 6/6. It was 6/12. Little less acuity. The conjunctiva was hyperemic. That means there was mild redness of the conjunctiva. And you see those spots. I've stained the cornea. You can see all those punctate keratitis, those spots which are staining on the cornea. Here you see all these spots. This is not a healthy cornea. Cornea should have been clear. And the tear breakup time, when you put a drop of fluorescein and wait for the breakup of the tears, it should come after 10 seconds, which you can measure on a stopwatch. The breakup time was only 1 second. That means whatever tears were forming were poor quality and they were breaking up very fast. And fluorescein staining was 4+. There's a lot of staining of the cornea, as you can see. There shouldn't be any staining of the cornea in normalcy. So then I said, let's do some more investigations for a systemic disorder. So I asked for ANA or anti-nuclear antibody test, which was quite positive, 1 in 128. Below 1 in 50, you don't bother. But ANA was positive 1 in 128. So I suspected Sjogren's disease. Sjogren's disease is where you get dry mouth and the dry eye. You can get dry vagina as well in a female. So the anti-Sjogren's A antibody was positive, anti-Sjogren's B antibody was negative. I stained with lissamine green, that's another stain, and that also showed a staining 4 plus. The Shermer's test, where we put a filter paper in the eye, which should get completely wet, about 35 millimeters wetting in 5 minutes, was very dry. Only 1 millimeter was wet in 5 minutes, which showed that predominantly the aqueous component, because Shermer's measures the aqueous component of the tears, which is secreted by the lacrimal glands. So it is almost nil. So the patient had very, very dry eye with an aqueous component deficiency. So therefore, the diagnosis was primary Sjogren's syndrome. Sjogren's syndrome can be primary Sjogren's syndrome where there is no cause found. It's an autoimmune disorder, but you can also have secondary Sjogren's syndrome. We'll come to that. So patient was on artificial tears already, but was not responding because mere artificial tears, when the problem was a systemic autoimmune disorder, was inadequate therapy. So what did we do? The doctor had prescribed, if you see the blue part, non-preserved artificial tears, 1 drop in each eye 6 times a day. So we added loteprednol, which is a mild steroid, 1 drop 3 times a day for 10 days, and I tapered it down so that the mild steroid can act because it's an immune disorder. And I put the patient on topical Restasis or cyclosporin 0.05%. I have no commercial interest, so approximate for any product. So topical cyclosporin, what does topical cyclosporin do? It stimulates the lacrimal glands to produce better quality tears. So it's not an artificial tear. It's not a tear substitute. It is a stimulant for the lacrimal glands. It comes as usually preservative free, and you have to put it for 1 to 2 years. So I started the patient on 1 drop in each eye twice a day. I put the patient on omega-3 fatty acids because that also stimulates the lacrimal glands to produce better quality tears. And I put the patient on something which helps the body's immune system, which is hydroxychloroquine. We give it also for rheumatoid arthritis patients, 200 milligram twice a day. So we did a gestalt approach or a holistic approach, not only artificial tears, which I continued. I added mild steroid for 30 days, but I also gave some other treatment, and the results were very gratifying. Symptoms almost disappeared. Shermer's test increased from 1 millimeter to 2 millimeters within a few days. So it started showing effect. The lissamine green staining, which was 4 plus, became 1 plus, so it reduced. Corneal fluorescein staining resolved. The patient is still on Restasis 1 drop twice a day, and the unpreserved artificial tears, which have come down to 4 times. So patient improved with the treatment. Let's see patient number 2. So this was a male, 65 years old, redness, blurred vision, burning, red eyes, foreign body sensation in both eyes, worse in the evening. Now again, using only your ears of what this patient has said, you've already diagnosed this is dry eye. Since 2 years, he's been having this. What are his comorbidities? Rheumatoid arthritis. You can see the fingers of his, which I've shown over there as a picture. Typical rheumatoid arthritis hand. For 10 years, he's been treated with methotrexate. So the physician is looking after his rheumatoid arthritis. Current therapy was unpreserved artificial tears plus methotrexate is going on. Patient still had only partial relief. So we searched for clues. Visual acuity was good. There was conjunctival hyperemia, few punctate spots that you can see, mild lid margin keratinization, because when there is dry eye for a long time, the lids get keratinized. The openings of the meibomian glands get closed, and meibomitis was there, meibomian gland disease. The tear breakup time, I told you, should be 10 seconds, was only 3 seconds. There was a lot of fluorescein staining, and the eyes were floppy eyelids. The eyes were very lax. That means we know that the blink action is not so great. So we went ahead and investigated. Shermer's test was very poor, only 2 millimeter wetting when the paper should have got wet fully, 35 millimeters. Lissamine green staining was 3 plus. So what did I do differently now? We diagnose this as secondary Sjogren's syndrome. Secondary is where we find the cause. So previous was autoimmune. Here this was because of rheumatoid arthritis. Patient was on artificial tears, but only partially responding. So here, what did we do? I increased the amount of methotrexate to 12.5 milligram per week, uh, continued with the artificial tears, added sodium hyaluronate, which works for which is a little thicker solution, works for longer time. I added some steroids, again tapering it dose, and added the Restasis and put a gel as well in the night and continued with omega-3. So again, a full tailored approach to this patient, and the patient did improve. We'll go to patient 3. Again, a female. This picture is only for representation. We're not, the Queen of England was not my patient. So 60-year-old female with burning redness, foreign body irritation, typical symptoms of dry eye, 2 years. This patient had no comorbidity. Again, was an unpreserved artificial tears. There was lid hygiene, so the doctor was looking after the lids. Short-term fluorometholone, so steroids was also given short-term, but still the patient had only partial response. So visual acuity was not bad, 612 in the right, 69 in the left. OSDI is ocular surface disease score, the disease index. So this is, we put a questionnaire, ask the patient how bad the dryness is. The higher the score, the worse it is. OSDI should be just about 9 to 12. 66 is a very high score. So patient was feeling very dry. The breakup time was only 2 seconds, again showing that it is quite a severe dry eye. Lissamine green staining was there. Schirmer's was very poor, and there was obvious meibomian gland disease. So what did I diagnose? That it is a chronic mixed dry eye. Schirmer's is low, so aqueous deficiency. Meibomian gland disease, so lipid deficiency. So patient was only on artificial tears, which helps only aqueous deficiency, was not responding. So what did we do? We added punctum plugs. First we put the patient on Restasis to improve the quality of tears. Once that was done, then I put punctum plugs to block the openings of the tear ducts so that her own tears would stay in the eye for a longer period of time. And because of meibomian gland disease, we had oral doxycycline. A side effect of oral doxycycline is to regulate the lipase activity in the meibomian glands and improve MGD. So 100 milligram daily for 3 months. If you write this, you have to tell the patient, don't listen to chemist, because chemist will say that the doctor has given overprescribed. But you know what you're doing. Doxycycline is to be given for 3 months. So we did this combination of treatment from MGD as well as the punctum plugs. Symptoms considerably decreased. Schirmer's improved, and the patient did not need a second treatment with LipiFlow. LipiFlow helps to get the lipid out of the lids. It's an expensive treatment, but just continuing with this did not need a second treatment. Thank you so much. I hope I've made things clear to you. The ABCDE of dry eye, the symptoms and signs that you can pick up without instruments, and from 3 case studies, how to have a proper scientific approach to management. Thank you. Arpita, all yours.
Yeah. Thank you, sir. Thank you so much for the insightful talk. Now let me go ahead with the questions. The first question is, among the ABCDE components, which one do you feel is the most overlooked in routine clinical practice, and how can we address that gap?
A very good question, Arpita. I feel that the computer vision syndrome is most overlooked. The blinking, B for blinking, is most overlooked. People don't ask a history. And patients themselves don't realize. I've had computer programmers who sit for 16 hours in front of the laptop. They get up and just go to the bathroom and splash their eyes with water because they don't realize that they've got dry eye. There's a lot of literature, there's a lot of work on Google, but still, I still get daily patients who are not aware that infrequent blinking can cause dry eye. So I just teach them to blink more often and the dry eye goes away. They don't need medication. So that is something which all family physicians also should explain to patients, that just blink more often and every 30 minutes, just close your eyes for a couple of minutes. Thank you.
Right, sir. Thank you so much for answering the query. Next question is, with the increasing screen time in both younger and older population, Are you seeing a shift in the demographic profile of dry eye patients?
Very much, Arpita. Exactly what I said in the last question. Earlier, we used to see dry eye only in the elderly population. But with the shift, everyone is on mobile phones, even children. I'm finding 5-year-old children with dry eye because they're sitting on the screen for 4 hours and 5 hours a day. Parents use the screen as a surrogate mother. When the parents are both working, they put the screen there and allow the child to watch. So many children don't eat food without the screen. So I'm seeing this in younger and younger age group, and we need to educate parents. It is not the children's fault. Thank you.
Right, sir. Very right, sir. The next question is, how do you tailor treatment in patients with both evaporative and aqueous deficient dry eye? Is there a preferred order in addressing these components?
Yes, you have to address every component. So if there is a tear aqueous component deficiency, you have to give topical cyclosporin to improve the aqueous and add tear supplement drops. But you have to look at the meibomian glands. If that is insufficient, you have to treat the meibomian gland disease. You have to express the extra mebum by hot compresses and oral doxycycline and topical azithromycin. These are some of the ways to address the meibomian gland. Unless you do a complete approach, you just for a dry eye, giving artificial tears is not the answer. Thank you.
Thank you so much, sir. There are a few feedbacks that have come in. So they're written like a very nice session, very nice presentation. Thank you, sir. Thank you, Dr. Maskati. So there are many feedbacks. There is one more question.
Yes.
Could you elaborate on how newer diagnostic like osmolarity testing or mammography fit into the structured ABCDE approach?
Right. So my whole purpose of this exercise was to make every person, whether you're a young practicing eye surgeon or you're a family physician, you don't need expensive equipment. Osmolarity, there is only one company called Tear Lab which makes it's very expensive and it is not very specific and sensitive. So unless you're a research place doing research, you don't do osmolarity. As far as memography is concerned, I use it because I am a dry eye specialist. I have all the equipment. We use it only to convince, to show the patient that, look, your oil glands are not working. So with memography, you can actually take a picture of the oil glands and show them and convince them to do hot compresses, convince them for the treatment. So it is more to improve patient compliance, not as a help to me for diagnosis. Thank you.
Right, sir. Sir, these were all the questions for today. So before wrapping up with the session, I would like to thank you for an
Thank you.
insightful and enriching presentation. And sir, thank you once again for being with us, and thank you all for the participation. So I sincerely appreciate the time and effort that you have taken to share your expertise with us today. Thank you so much, sir.
Thank you. Bye-bye.
Bye, sir. Take care. Thank you all for joining in. Keep joining the sessions and keep putting your questions.